Hello, my name is Jeff Reist, and I'm a clinical associate professor at the University of Iowa College of Pharmacy. I also work as a clinical pharmacy specialist in the geriatric clinic at the University of Iowa Department of Family Medicine. I've been working with older adults for many years, and I'm very happy to be with you today to talk about a couple strategies we can use to reduce risk of negative health outcomes in older adults. I'm going to talk today about two strategies that I use every day in clinic. One is the Beers criteria, which I'm sure many people have heard of, and the other is immunizations. We have some immunizations now that are very effective for the use in older adults to prevent infectious disease. So I'm going to talk about both of those. But first of all, I want to let you know I have no conflict of interest. I have nothing to disclose. And our learning objectives today are pretty broad, really. We're going to talk about the Beers criteria. We're going to understand how the Beers criteria are structured. We're also going to use them. I do believe in the best way to learn something is to put it into practice. So we have a couple cases that we're going to apply the Beers criteria to, and we're going to walk through those together. And then I'm going to end the presentation with a very short update on immunizations, because there's been some changes in immunization recommendations lately for adults over 65, and I want to make sure that everybody is clear on those because, quite frankly, they're a little confusing. So the Beers criteria, we're going to start with that. The Beers criteria were updated just recently, earlier this year in 2019. They are published now by the American Geriatric Society, and they're located at their website. You can go there to find them. You can also find them in their journal, the Journal of the American Geriatric Society. I've got the citation listed here, and I highly recommend finding that article. It's quite readily available. It is an amazingly well-written article, and it has all of the tables that I'm going to talk about. You can also go to the American Geriatric Society website and find tools there that are based upon the Beers criteria. In fact, one that I use a lot in teaching student pharmacists and medical students in clinic is the pocket card of the Beers criteria. It's very nice. It fits in your pocket, and there are also apps for your phone as well. So I want to talk a little bit about the history of the Beers criteria. The Beers criteria have been around for almost 3 decades now. And interestingly enough, it started as a very simple list. In 1991, Dr. Mark Beers just published a list of medications that we probably shouldn't be using in people that live in nursing homes. And it was a very interesting list. It was a list of medications, some of which were widely used, some of which weren't widely used. But it really caused people to look differently at medication use and these potentially inappropriate medications and what I call medication misadventures that can occur in older adults. This list was relatively short, and if you looked at that list today, and I sometimes do, it's quite interesting. Most of those drugs aren't on the market anymore. And I truly believe that Dr. Beers was responsible for some of those drugs being removed from the market, which is a very good thing. A medication that was on the early Beers criteria, which was widely used at the time, propoxyphene or Darvon or Darvocet for pain, we knew for years, I learned it in pharmacy school, that was a dangerous drug, especially in older adults, and it really wasn't any more effective than Tylenol. And it was on the list for a number of years, and it took several decades, but it was removed from the US market, and rightly so. Over the last 3 decades, it has been expanded and updated. Most recently in 2012 and 2015 and now the 2019 updates, the Beers criteria have partnered with the American Geriatric Society, and they have kind of taken on the management of this very important tool. And as I mentioned earlier, the latest update was in 2019, which we're going to talk about today. So the Beers criteria is really not just a list anymore. Again, it started out as a list. It was just a whole bunch of medicines thrown together. Just, probably shouldn't be using these. It's now developed into a much more robust and useful tool consisting of a series of tables. And I'm going to go through some of those tables with you, the ones that I find most useful in my practice. Table 2 is the table that probably most of us are familiar with when we think about the Beers criteria. And it kind of goes back to that list that Dr. Beers came up with almost 30 years ago. and that's the potentially inappropriate medications. Sometimes you'll hear these referred to as PIMS, P-I-M, and it stands for potentially inappropriate medications. And it's just a list, and it has the medications that are potentially dangerous in older adults, and it kind of gives you some of the reasoning, as well as the quality of the evidence. And I'm not going to go into great detail of that right now, but for each one of their recommendations, they've actually gone through a very rigorous scientific analysis of the data. And they tell you whether the evidence is very strong, whether it's relatively weak, and what quality they have. So it's very, very interesting. If you're interested in that, you can find that as well. Table 3 is another table that has been in numerous revisions of the Beers criteria. And this is that what we call drug disease, drug syndrome list. And these are medications that by themselves, may not be so bad. They may not be horrible for a given person to take. However, a person that has a certain drug or a certain disease state or syndrome might actually be harmed by this medication. And we'll go through some examples of that when we do our cases. Table 4, I call this the not ready for prime time list. These are medications that, many of them are relatively new to the market. They're potentially inappropriate, but we should probably use them with caution. And, the authors of the criteria are not willing to say, these need to go on table 2 right now. These are medicines that, we're still learning about them. We probably better be careful and just be aware of those. Table 5, drug-drug interactions. Now, any of us that work with electronic medical records or pharmacy dispensing systems are very, very accustomed to when we enter a medication order and you hit send or enter or whatever you do, if that medication is on a list with other medications, you're often going to have drug interactions show up, some of which are potentially fatal. They can be life-threatening drug interactions. Some of which, on the other hand, are just kind of those theoretical things that, it may do this, it may not do that. Well, how do we know? How do we as clinicians know how important that individual drug interaction is? It's something that I think we all struggle with. This table actually has some clinically important. So these are drug interactions that have been shown to really be the real thing. They can really cause harm, and it's not overwhelming. So you can look at this list and you can apply it to your medication regimen. Table 6, okay, as we get older, our kidneys, they don't work as well. That's just the way it is. That's a fact. So, every decade we lose a certain amount of our kidney function, and that's very, very important when we're talking about medications, because medications are oftentimes eliminated from the kidneys. Now, some of them are eliminated through hepatic metabolism, some through the bile and those kinds of things, but many of our medications that we use in older adults are relying on adequate kidney function to excrete these medications. So what happens, when our kidneys aren't working as well, these medications tend to accumulate in the body. Which you might say, well, isn't that good? I mean, we get more medication. Well, not necessarily. Some medications have what we call a narrow therapeutic window. So there's a narrow range between the toxic level and the therapeutic level. And if we have more medication than we anticipate, we're going to have a toxicity. So we have to be able to what we call renally dose these medications. And this table 6, lists some very commonly used medications that aren't, by themselves inappropriate in older adults. But we have to look at the kidney function, and we have to make decisions on dosing and dosing intervals based on that kidney function. And then table 7, the last table that I'm going to talk about today, is that list of highly anticholinergic medications. So many of the medications on the Beers criteria end up there because they're anticholinergic. And anticholinergic means that they work on that cholinergic nerve system in our body that controls many, many functions, everything from our cognition to our bowels. So when you think of anticholinergic drug side effects, you think of drying, you think of, dry eyes, dry mouth, slowing of the colon, constipation. You think of cognitive impairment. One of the theories of Alzheimer's disease is that we have a relative lack of cholinergic activity in the brain. Well, anticholinergic drugs can mimic that. So we've actually had many cases in clinic where we've done a cognitive assessment on a patient and they've screened as having mild cognitive impairment. We've eliminated the anticholinergic drugs from their medication regimen, and they've gotten back into the normal range. So don't underestimate the importance of looking at a medication regimen for what we call anticholinergic burden, and this table 7 can really help you do that. Okay, I do want to talk in the next section about some of the additions. So what is different about the 2019 Beers criteria from the previous edition? So some of you may have been using those. I use them in both my clinic practice and in my teaching. So what's different? What do we need to be aware of? So I'm not going to go through absolutely everything that's changed, but I've picked out what I consider the highlights. So one big highlight that I think has gotten some press is the addition of some drug interactions, one of which is a commonly used antibacterial drug, trimethoprim sulfamethoxazole, abbreviated TMP SMX, and this is commonly used in older adults for urinary tract infections. Another medication that we commonly use in older adults for everything from hypertension to heart failure is ACE inhibitors, things like lisinopril, enalapril, benazepril, different ACE inhibitors. Another group is what we call the angiotensin receptor blocker agents, which are ARBs, which are also used for some of the same indications as the ACE inhibitors. So we have a lot of people on those ACE inhibitors and ARBs that get temporarily put on this Bactrim, trimethoprim sulfamethoxazole. Bactrim is a brand name. And especially in the case of reduced kidney function, which we've talked about, and you can look at their kidney function based on their serum creatinine and calculate their creatinine clearance, you find this increased risk of hyperkalemia. So high serum potassium, which can be fatal, can cause fatal arrhythmias and all kinds of problems. Another drug that we commonly see in older adults, not as often maybe with the advent of some of the newer anticoagulants, but we still have many, many older adults on warfarin. Warfarin, as we know, is fraught with drug interactions. We've been learning those and managing those for decades. But warfarin with antibiotics such as ciprofloxacin and certain macrolides of note, not azithromycin, however, or with the SMX TMP we mentioned earlier, the trimethoprim sulfamethoxazole. Those antibiotics can really make warfarin more effective, which again, in the case of warfarin, being more effective than it needs to be can increase the risk of bleeding, so we don't really want that. Opioids. Now, I think most of us are doing everything we can to minimize the harm of opioids in all ages. I don't think you could think of anybody that's in healthcare that's not aware of this problem that we have that we're working with. Older adults are very susceptible to opioid toxicity, primarily respiratory depression and falls. And we do know now that, and we've known for a long time, that combinations of opioids in certain drug classes like benzodiazepines, things like lorazepam or Xanax, Ativan or alprazolam, those kinds of drugs, when we mix them with opioids, tend to really increase that risk of overdose. And overdose in older adults, and actually all age groups, is often manifested by severe respiratory depression and death. So we want to avoid that combination whenever possible. And in actuality, benzodiazepines are also listed on the Beers criteria as potentially inappropriate and have been for many, many decades, because we just feel that whatever benefit we might get from benzodiazepines in older adults is often outweighed by the risk. However, there's another group of drugs that we use a lot for pain in older adults, and that's things like gabapentin and pregabalin. And these drugs are often used for not only neuromuscular pain, which is kind of what they were originally used for, but we also use them a lot for musculoskeletal pain. And we've often used them to try to spare doses of opioids, to try to minimize opioids. So we do have some people that either for a short period of time or for long periods of time are on both opioids and gabapentinoids. And just so you know, that is another risky combination for both sedation, respiratory depression, and of course respiratory depression can lead to death. What about other pain medications? So tramadol has been around for a number of years now. Originally, it was marketed as a safer alternative to opioids. We now know that it really isn't a safer alternative to opioids. It has its own series of problems, many of which are just like the opioids, but in addition, it has things like this increased risk of hyponatremia or low serum sodium and SIADH. So if we put a person on tramadol, especially if they're on other medications known to cause this, things like diuretics, like hydrochlorothiazide, furosemide, and antidepressants, all of the SSRIs and SNRIs have been associated with this hyponatremia as well, so we do have to be careful of that. And I would highly recommend in older adults, which tend to often have slightly lower serum sodium levels anyway, to monitor that serum sodium when you put this combination together. Okay, aspirin. I think aspirin has been in the press a lot lately. There's been several studies that have come out kind of about the same time the Beers criteria came out, really questioning the value of aspirin for what we call primary prevention. And I want to make sure everybody's clear on when I say primary prevention. I'm not talking about the person who's had a heart attack or an MI or an ischemic stroke that needs to be on aspirin. I'm talking about the person that has had none of that. They don't have cardiovascular disease. They don't have any angina. They haven't had stents placed, all of those things for which aspirin is a highly effective treatment. I'm talking about people that have none of that we're just actually trying to prevent that first heart attack or stroke. And the guidelines are pretty clear now that for people, especially older adults, the risk of aspirin is not worth the benefit for that primary prevention. The Beers criteria had this before for people over 80, but now it includes people over 70 for this primary prevention because that increased risk of bleeding with no significant difference of reduction in the incidence of cardiovascular disease. Anticoagulation has been a big topic since the advent of what we call the DOACs, the new non-warfarin anticoagulants. Many of them have been on different lists. They've been on the caution list, so rivaroxaban now joins dabigatran on the use with caution list. Remember, that's that list for drugs that we're still learning and we maybe are, finding some potential issues with certain older adults. But rivaroxaban, dabigatran are both on that list now for both atrial fibrillation as well as venous thromboembolism for people over 75, because what they've found through post-marketing reports is that those folks in that age group have an increased risk of GI bleeding with those two agents. So we're all very interested in anything we can do to prevent falls and fractures in older adults. The SSRIs and the tricyclic antidepressants, things like Celexa, Zoloft, and then the older tricyclics, things like nortriptyline and amitriptyline, have been on the Beers criteria for a number of years now as potentially causing falls and fractures. Well, now they've added that other group of antibiotics, the SNRIs, things like venlafaxine or Effexor, duloxetine, Cymbalta, those kinds of agents are actually on the list now as well. Now, they do add a caveat on this, unless alternatives are unavailable. And quite frankly, we really don't have any other alternatives right now. We have bupropion, which is probably the only one that is not an SNRI or an SSRI or a tricyclic. But there's not a lot of alternatives. And this is one of those cases where you really have to do a risk-benefit analysis. Like, we know depression is risky. We know depression has lots of negative outcomes. And I am not at the point where I am eliminating these classes of antidepressants from my older adults' medication regimen, because many of them need to be treated for depression. I need to take other actions sometimes to manage their fall risk and fracture risk. But I don't want you to think, based on the fact that now we have all of these classes of antidepressants listed as potentially contributing to falls, that they shouldn't be used. I think there's many cases where they absolutely have to be used. Diabetes, we've had glyburide on the Beers criteria as a potentially inappropriate medication of all the oral sulfonylureas. It was the one with the longest, or causing the longest incidence of hypoglycemia or low blood sugar, which is potentially fatal in older adults and certainly causes a lot of morbidity from falls and problems. Well, glimepiride, which has been widely used in older adults, now joins glyburide. So we now have two of the formerly commonly used sulfonylureas added. So glipizide would be the only one alternative to that. Then that last table, which is the anticholinergic list, a couple anticholinergics have been added, pyrilabine and mescopolamine, which have been added to that list that we should probably avoid. So what about removals in this update? So every year, or every time they update the Beers criteria, we have additions, but we also usually have some removals. And sometimes the removals are because the drug's no longer available, which is probably a direct result of being on the Beers criteria. Well, let's talk about what's happened in that area. So we have a couple medications that have been taken off the market, medications we really haven't been using very much. They've been replaced by other more effective and certainly safer medications, ticlopidine and pentazocine. Ticlopidine was an antiplatelet agent, been highly replaced by things like clopidogrel. Pentazocine was kind of a strange pain medication that really was its own class, but had lots of side effects that caused it a lot of problems. Another large group of medications that has been removed, I want to take a minute to talk a little bit more about, which is the H2RAs, which are the histamine 2 receptor antagonists, which is a long name for what we call the acid reducers. Now, these are acid reducers that basically cut down on acid suppression. These are drugs like cimetidine, ranitidine, famotidine. We're not talking about what we call the proton pump inhibitors here, the PPIs like Prilosec and the purple pill and all of those things. We're talking about a class of drugs that is less potent at reducing acid. And in fact, with the problems that we have with that other group, the proton pump inhibitors, things like omeprazole, Prilosec, pantoprazole, we're actually trying to switch people to this group, the H2RAs, the things like ranitidine, famotidine. So I think the people in the Beers criteria realize that having this class of drugs on the Beers criteria actually was kind of a negative, in that it made people think, well, we can't really switch them to these. But they've actually decided that the evidence for their association with dementia is relatively weak. And because we think these are safer in older adults than that other class, they took them off the list, which I think is really commendable, because I personally feel that this class of drugs is relatively safe in older adults, and it is safer than that other class. There's other medications that when I first looked at the removals without reading the reasons, I was thinking, wow, I wonder what was back behind that. Once you read the reason for them, though, I think it's pretty clear. They had some medications on the list that were potentially inappropriate in not only older adults, but pretty much everybody. So they felt like this list is really about older adults, so should we have medications that are inappropriate for everyone on the list? And they decided, I guess, no. So things that exacerbate insomnia, things like oral decongestants, things like pseudoephedrine, stimulants, those kinds of medications used to be on the list, usually on the table that listed the drug and drug disease state interactions. So people that had insomnia shouldn't take these. Well, they've been removed from the list. Not because it's not a problem, but because it's not just a problem only with older adults. Medications to avoid in seizure disorder, again, bupropion, tramadol, those are both relatively contraindicated in folks with seizure disorder. However, it's not just older adults, it's everybody. So, it doesn't say that now we can use tramadol with seizure disorder. It just says that we probably should think of that risk in everyone, not just older adults. And then the last major group that was removed was some vasodilators, which vasodilate, obviously, which is certainly going to increase the risk of fainting in a person with a history of syncope. Okay, so enough of that. Let's do something a little bit more fun now. Let's talk about using the Beers criteria, and these are cases from the clinic. So these the cases we're going to go through are cases of amalgams of people I've seen over the years that I've worked in geriatric clinic and how I've used the Beers criteria to minimize the risk of their medication regimen. So let's first talk about Jim. Jim's an 82-year-old male, relatively short medical problem list. He has hypertension. He has mild cognitive impairment. It's been getting worse lately. I'm not sure what's going on there. And he has BPH and osteoarthritis, so benign prostatic hypertrophy, which many older gentlemen will have, which certainly causes a lot of morbidity as far as being able to pass urine. So he comes to clinic today. His vitals are taken there. He has some orthostatic blood pressures there. And you can see from his blood pressure readings, his sitting, standing, he is orthostatic. So he does have a reason, for maybe being a little lightheaded. Pulse is there, temp is good, respirations are there. His chief concerns today that he expresses, or his caregiver might express if he's with one, is that he's getting out of bed at night. Many gentlemen with BPH have to get up multiple times a night to urinate, and that's a dangerous thing. Just as simple getting up at night in the dark, maybe being half asleep, stumbling around, increased risk of fall. So he's been falling a little bit. He gets up multiple times a night to urinate, so that's an increased risk. He does have dizziness, and he has some syncope. And his family's concerned about his confusion getting worse. The medication list looks relatively short. I mean, most of us would say, wow, you're 82 and you're on 4 medications. That's really pretty good. Is that polypharmacy? I mean, we haven't really talked about polypharmacy yet, but I mean, there's lots of definitions of polypharmacy. I don't tend to like a number. I like to think of polypharmacy as anytime we have inappropriate medications ordered. And let's look at this. And some people say, well, he's on 4, that can't be polypharmacy. But I would say, let's look at the Beers criteria, and let's see what we come up with. So the next few slides, I've taken some screenshots of the pocket card of the Beers criteria, and I'm going to use those to show you how we use the different tables. So table 2, this is an excerpt from table 2. Table 2 is a fairly long table. Remember, it's that original table. It's the original list of Beers criteria. So if you look at table 2, you'll see that one of his medicines, diphenhydramine, is on the list. Diphenhydramine, also known as Benadryl, has for years been touted as a safe alternative for older adults for sleep. And I will tell you that it is not a safe alternative for older adults in sleep, and it's been on the Beers criteria for years. And the reason it's not safe is it's highly anticholinergic. And remember, we talked about anticholinergic drugs having that tremendous range of side effects, everything from affecting our thinking to our gut and everything in between. So it is not a safe anti-insomnia drug, and he's been on it. So I would suspect that this is somehow helping to, or not helping, but harming his cognitive impairment. What else is he on? Well, he's on terazosin. Terazosin is an alpha blocker. Alpha blockers originally were marketed for blood pressure because they vasodilate. They block the alpha receptors and they cause vasodilation. Vasodilation can be good for lowering blood pressure, but guess what? It tends to lower blood pressure maybe too much, especially when we go from standing to sitting or sitting to standing, and it can cause this thing called orthostatic hypotension. So why is he on terazosin? He's on terazosin because he has BPH. The alpha blockers, doxazosin and terazosin, historically have been used to block the alpha receptors in the prostate, because by blocking those, we actually open up the urethra and we allow urine to flow better. So a simple solution to him would be to switch him to what we call a selective alpha blocker, one that works only on the prostate and not on the receptors. Something like tamsulosin or alfluzicin would be appropriate. And this slide, I can tell you, is hard to read, and I'm sorry about that, but this list is very long. And this is a list from Table 2 of potentially inappropriate medications, which are the NSAIDs, the non-steroidal anti-inflammatory agents. And most of us have probably had experience with these drugs. I mean, they're available, many of them over the counter: ibuprofen, Advil, naproxen, Aleve. Those are medications that I think most of us have had experience with. But in older adults, they can be a big problem. He's on ibuprofen for his osteoarthritis, and it should be avoided in chronic use. Now, I want to make sure everybody is aware of this chronic use here, because sometimes we do need to use these drugs for acute use, like an injury, a fall where they've pulled something or broken something. We're going to use some of these drugs, but we're going to use them cautiously, and we want to be very careful not to have that convert to chronic use, because chronic use is associated with all kinds of problems, including gastrointestinal bleeding and also fluid retention and hypertension. So let's look at table 3. Remember, table 3 was that list of drugs that would be potentially problematic in people with certain other conditions. So, we know that our patient has syncope, so he's been having some dizziness and falls. So if we look at this list of medications, we can say, is he on any of those medications that are associated with that? Well, again, he's on that terazosin, which is the non-selective alpha blocker. So you can see how the tables kind of work together. So terazosin is on table 2, and it's also on table 3. So, you can often use the tables kind of interchangeably. I tend to think of using them all because some you might show up in multiple tables, but if you don't use all of them, you actually might miss them. What about table 7? Table 7 is that list of highly anticholinergic medications, and it's a fairly long list, and I've just pulled out just one little section of it. The nice thing about table 7 is it's organized by drug class. So this is the antihistamine section, the first generation, and you can see that, of course, good old diphenhydramine, which he's using for sleep, is listed right on there. And so that would be another place where that drug showed up on 2 different lists. So that was Jim. Let's talk about Jean now. Jean is our 78-year-old female. Her medical problem list is a little bit more complicated. She has type 2 diabetes, she has hypertension, she has heart failure, she's class 2, she has ejection fraction of 30%. She does have chronic kidney disease, stage 3, so her ability to get rid of medications is going to be harmed by that stage 3 chronic kidney disease. And she has gastroesophageal reflux disease, or GERD. So you can see that, you can kind of imagine in your mind, if you know Jean, what kind of medications she's on. So let's take a look at that. So her list, let's look at the vitals first, I guess. So here's her vitals. Her blood pressure is pretty good today. It's 134/72. Pulse is hanging in there. A1C is 7.8, which, depending upon, which guidelines you're using and her age, you might think, well, maybe we could do a little bit better there, or maybe that's okay. Serum creatinine, 1.3. Calculation of her creatinine clearance, which is that estimation of renal function, is 35. So you can see she's definitely in stage 3 chronic kidney disease. So she's, above 30, which is a big cutoff for drug excretion, but she's certainly below 50 or 60, which is kind of another creatinine clearance milestone we look at. Chief concerns, she's been independent for her activities of daily living until the past few weeks, although she's recently more forgetful, confused, been more nauseous and weak. She was diagnosed with a UTI, and certainly a UTI in an older adult can cause some of those symptoms 3 days ago. And she was started on SMX-TMP-DS, the sulfamethoxazole trimethoprim, which we talked about earlier. Here's her medication list. Finally, it's a little bit longer than Jim's. She's on glimepiride for her type 2 diabetes. She's on furosemide, which is a loop diuretic for her heart failure. Lisinopril for heart failure, ACE inhibitor, metoprolol, a beta blocker for her heart failure. So as we know, when we have heart failure, we're going to be on at least 4 or 5 medications. She's on potassium, which is going to hopefully counteract the potassium wasting of the furosemide. She's on ranitidine, an H2RA blocker for her GERD. She takes that twice a day, of note. She's taken ibuprofen. She has arthritic type pain. She just occasionally uses this drug. And when people report to me that they're using this as needed, we do need to make the next step, which is how often per week or per day you're using that. And when we ask her that, she says she takes it about 6 to 8 doses per week, so about every day. So she's taken a dose about every day. And then, of course, she's on the antibacteria SMX TMP DS twice a day for 5 days, which she started a couple days ago. Okay, so let's look at the tables, see what the tables tell us about genes list. So when we apply genes medication list to the tables, we look at the table 2, and we talked about this a little bit earlier. Glimepiride has been added to the Beers criteria in 2019 as a sulfonylurea to avoid, and we avoid it because of its prolonged risk of hypoglycemia. And a lot of it is, all of the sulfonylureas, including glipizide, which is not on this list, can cause hypoglycemia, and that's a big, big concern in older adults. But the ones that are on this list are actually more harmful because if you do get the hypoglycemia, it lasts a long time, and that can be more severe. Let's look at table 3. She has heart failure, okay? Very serious condition, which can be exacerbated by a lot of things. It can be exacerbated by our diet. It can be exacerbated by our medications. So is she on any medications that is going to potentially exacerbate her heart failure? Well, she is. She's taking ibuprofen, which is an NSAID. And NSAIDs cause all kinds of issues with heart failure because they work on the kidney, and they can cause fluid retention. Just like eating that huge piece of ham at Easter time, which causes a bunch of sodium, which causes fluid retention, which causes many heart failure exacerbations. Taking doses of ibuprofen every day can cause fluid retention. And whenever we have extra fluid in the body, that's harder for the heart to work. So it's really, really difficult to push that blood, and that failing heart just can't keep up. What about table 4? Medications to be used with caution. Well, here we have trimethoprim sulfamethoxazole, which should be used in caution with people on ACE inhibitors or ARBs. Well, she is on lisinopril, an ACE inhibitor. So we do increase the risk of hyperkalemia. Again, that increase in serum potassium with a person with heart failure is going to be really, really dangerous because you're going to have some potentially abnormal heart rhythms. And if we have a failing heart and suddenly we have a heart that's not beating rhythmically, we have all kinds of problems. So very, very dangerous interaction there. So we haven't used this table yet. This is the table 6, which is medications to think about maybe not using or reducing doses for various levels of kidney dysfunction. So we have ranitidine on there. Ranitidine was removed from the potentially inappropriate list. So table 2, it was removed from that. However, it does remain on table 6 because it does have renal excretion. So ranitidine depends upon good kidney function to be excreted. And if we have people with creatinine clearances less than 50, and hers, remember, was 35, we're going to run into dose accumulation. So we're going to have, we're going to take, and she was taking 150 milligrams twice a day. And what we would find is that as time progresses, she's going to have an increasing blood level of ranitidine, and that increased level can still cause the toxicity and probably cause some cognitive impairment. So we would reduce the dose. In this case, we would probably reduce it from twice a day to once a day. Okay, so that's the Beers criteria. So I hope that you've got an appreciation for how this list, if you just look at it as a list, I think it's overwhelming. And if you look at it and say, I'm going to memorize all these, I think that's not necessary. I think the use of the Beers criteria that I have found and what I've tried to teach learners about is to look at the medication regimen and then apply that regimen to the tables. That's the best way to use it when you're learning. And when you do that over and over again over a number of years, you will have memorized those drugs because the same ones come up over and over again. And you won't have to go through the trouble of trying to memorize them all. It will just become part of your practice to the point where you don't even need the Beers criteria anymore because you've adopted the principles of the Beers criteria in your practice. So all you need to do then is look at the updates every 3 to 5 years and find out what's new. So hopefully that's the way I use the Beers criteria, and hopefully that will help you as well. Okay, we're going to shift gears here. We're going to talk about immunizations. So we're not going to do a whole immunization presentation here, but I do want to talk about a couple issues that have come up within the last 12 months, which have kind of muddied the waters a little bit. There've been some questions that have come up in geriatric clinic about immunizations. You know, there's a lot of talk about immunizations in the press, and I'm not going to even go into all of that, but I do want to talk about what is going on right now in adults over the age of 65. I'm not going to talk about pediatric vaccines. So I do want to talk about shingles. So shingles vaccine has been around for a while. We've had Zostavax, which is the live vaccine. It has been around for a number of years. We've had pretty good use of that vaccine, but we have a new vaccine called Shingrix, which maybe you've heard about. And I'm going to talk about why we have two now. So what is shingles? Well, I think most of us know somebody that's had shingles, or maybe we've had shingles ourselves, and we know it's a very debilitating illness. Shingles is a reactivation of a virus that most of us had as children, chickenpox, which stays dormant in our nerves, and for some reason, as we get older, usually over 50 or 60, that virus decides to come back as shingles. And what it does is it makes a nice little band, usually around the trunk. It can be on the face, it can be anywhere, but it's a band that follows a nerve, and it creates some very painful vesicles that are extremely debilitating for people, that eventually will heal. However, if we don't treat it properly with antivirals in a very expeditious manner, this can result in lifelong pain in that nerve called postherpetic neuralgia, which, you know, folks that have that, you know, really struggle as far as to control that pain. So anything we can do to prevent shingles, we should do it, okay? So we've had the older vaccine, now we have the newer vaccine, and it's called, and it's very confusing, so I've tried to call these two vaccines by all of the names, because when you read about them in studies, you know, it gets very, very confusing. So recombinant zoster vaccine, RZV, is also known as Shingrix. Okay, 3 names, it's ridiculous, but we have 3 names for it. The other one, which you can see at the bottom, is called ZVL, which is Zostavax, which is zoster vaccine live. Those are the 2 shingles vaccines we have right now. And I'm going to refer to them by their brand name now because I think that's the least confusing of all of them. So we've had Zostavax for a number of years. We now have Shingrix. That's the new kid on the block, okay? So Shingrix is actually the only vaccine for shingles that we're recommending now. We have quit recommending Zostavax, and it's mainly because of the efficacy. Shingrix is over 90% effective versus Zostavax, which is probably in the 30% effectiveness range, and it doesn't last very long. So the new guidelines are that Shingrix is recommended for everybody that is immunocompetent over the age of 50. And this is a big change because Zostavax, whereas it could be used over 50, was never recommended too strongly down to below 60, mainly because we didn't think it lasted that long. So being able to immunize somebody at age 50 to provide much more protection over that next decade of life is a very important advantage of Shingrix. And Shingrix is now, as you can see by the last bullet point, preferred over Zostavax for the prevention. So a little bit about Shingrix. It is an inactivated vaccine. So Zostavax was a live vaccine. This is an inactivated one. It is adjuvanted, so that means it's had something added to it to make it more immunogenic, so more effective. It does have to be given in a 2-dose series, so we have 0 and 2 to 6 months. So 0 is considered the month you get it, and then 2 to 6 months later you get your booster, your second shot. And it's very, very important that you get both. I will tell you from talking with lots of folks that have had zoster or that have had the Shingrix vaccine is that many people get a painful arm, and it lasts for several days, probably more painful than some other vaccinations. Although I've talked to other patients that said, no, it wasn't that bad. But it is a little bit of a more painful shot. However, everybody that has told me that, I said, have you ever had shingles before, or have you ever talked to anybody that had shingles? And they said yes, and it would definitely be preferable to get the shot and the pain than shingles. So just to warn you about that. The efficacy is listed there as over 90% in all age groups, which is an amazing efficacy rate for a vaccine. And even after 4 years later, in that age 70 group, it was over 85%. So many of us have heard our patients talk about, well, you ordered the Shingrix for me and I'm on a wait list at every pharmacy in town and nobody has it. What am I supposed to do? Well, unfortunately, or fortunately, I guess, depending on how you look at it, when Shingrix came out, the demand was overwhelming. You know, the company did not anticipate how many people would do it. I think they should have, because I think all of us that work with older adults realize that if we have a good way to prevent shingles, we're going to use it. So all of us, jumped on that and started ordering it for our patients, but we kind of overwhelmed the system. So, there are waiting lists, although that shortage is starting to dissipate, and I'm hearing more stories about people finally getting it. But what we started to hear several months ago was what happens if a person gets the first shot and they can't get the second shot for longer than 6 months. So remember, Shingrix is a 2-dose series, so we have to give a dose and then we give a dose 2 to 6 months later. Well, what happens if 7 months later we still haven't got the second shot because it's on shortage? What do we do about that? Well, we did find a phase 3 study which looked at that, and it said that if you gave it at 2 months versus 6 months, there was no difference. So it met the non-inferiority criteria. However, if you gave it at 12 months, it wasn't exactly the same. However, the effectiveness rate was still 94%. So it's still relatively high, but it wasn't as high as if you would have given it in the normal time range. So what we're telling people is that even if you have to wait, 8, 9, 10 months, you should still get that second shot. It may not be as effective, but it's still going to be over 90% effective. And then we're going to talk a little bit about pneumococcal vaccine changes. So many people have been confused about this, and I honestly can say I was confused too when the ACIP, the Advisory Committee for Injection Practices, came out with this recommendation to have a change from the pneumococcal vaccine regimen that we've been using since about 2014. So it involves this pneumonia vaccine, the pneumococcal conjugate vaccine, which is PCV13. And PCV13, you might recall, back in about 2014, a recommendation was made that we should give all adults 65 and older a dose of PCV13 in series with the older pneumococcal vaccine, the PPSV, the polysaccharide vaccine 23, which we've been giving for many, many years, commonly known as Pneumovax. So in 2014, we had some kind of confusion because many people had already had the PPSV 23, so when do we give the 13, and should we give it? And they basically came out with some fairly straightforward guidelines that people should get both. If they haven't had either, they should get the PCV13 first and then get the 23 a year later. So that kind of solved that problem. So since 2014, we've been trying to get everybody to get the second pneumonia vaccine, okay? But if you note on this timeline, we've been using a similar vaccine, the PCV7 and then the PCV13 for children since the beginning of this century, since around 2000. So that's going to be important for us to consider as we think about what is happening right now. So kids have been getting this for a number of years. You notice right now there's this evaluation of PCV13 in adults over or equal to or greater than 65. This is what we're going to talk about here, is what did that evaluation come up with and why is it confusing us so much? Okay, so the Advisory Committee on Immunization Practices in 2014, this is what I had mentioned earlier, they made this recommendation that we should give everybody over 65 and older both the 13 and the 23. And they made it very clear at that time, and I think most of us didn't pay much attention to this, but they made it very clear at that time that this was a short-term recommendation, and they're going to start looking at, over the next 3 or 4 or 5 years, they're going to look at this thing called herd immunity. Now, herd immunity is what we get when a whole population is being vaccinated. So how does that affect the non-vaccinated people? So these children, as the previous timeline showed, have been getting some kind of pneumonia vaccine since 2000. So what effect did that have on older adults? So in this 4-year evaluation that was done, they monitored the disease, both the indirect and direct effects of vaccination, and also the safety. And this slide, I'm sorry, it's kind of hard to read, but it's really looking at what we call the indirect effects. So this is the effect of all of those kids getting the pneumonia vaccine. Okay, so they've been getting it for a couple decades now. So what effect did that have on the incidence of IPD, which is invasive pneumococcal disease, in older adults? So this goes back 20 years to 1998. And you can see the blue line. Let's just look at the blue line. The blue line is all invasive pneumococcal disease. And look what has happened. And this is just in older adults, not children. You can see that blue line has made a tremendous drop, about a 50% drop. During this time period. And that was before older adults started getting the PCV13. Okay, so this is indirect. This is herd immunity. This is those kids not getting pneumonia and not giving it to older adults kind of thing. This is what's happened since 2014. Okay, so 2014 we started massively immunizing older adults with that PCV13 vaccine, and it's had no effect. It's a flat line. So I think, we've gotten the benefit of that herd immunity. We haven't gotten additional benefit from adding PCV13 to the older adult immunization schedule. So when the committee looked at this, they had basically 3 options. They had to decide whether they were going to continue to recommend the PCV13 in series with the traditional pneumovax, or they could say, no, we're not going to recommend it anymore because it hasn't had any effect. Or they could do something in the middle called shared decision making, which generally means the provider and the patient's representative sit down and they talk about it. These are the risks, these are the benefits. And then they decide as a group, which we do a lot in the care of older adults, what to do about that. So what did they decide? Well, they decided not to do that. They said they can't really look at the data and continue to recommend that everybody get that because the data doesn't support it. They weren't willing to go so far as to say, we're not going to even recommend it anymore. So they kind of went in the middle. They kind of went in the middle and said, you know what, some people it might make sense based on, very patient-specific conditions. Other people it may not make sense. So they kind of went in the middle. So here is the ACIP recommendation, which we all read and kind of scratched our head about until we looked at the data. They do recommend this PCV13 pneumonia vaccine based on shared decision making for anyone 65 and older. And again, these are non-immunocompromised patients. And they continue to recommend for everyone over 65 and many people under 65 based on other conditions that they still get the PPSV23. So what hasn't changed in the area of immunizations for older adults? We still recommend everybody get an annual flu vaccine. That has not changed, and we're going to be ramping up for flu vaccine season here. We still recommend a dose of Tdap, which is a tetanus vaccine, 1 dose of that, as well as a TD booster every 10 years. And then as the previous slide mentioned, we still recommend 1 dose of the PPSV, the polysaccharide or pneumovax vaccine in everybody 65 and older. Well, I do want to thank you for listening today, and I hope that this has helped you to come up with a few strategies to take care of older adults, to minimize some negative health outcomes. If anybody has questions, you feel free to email me at my University of Iowa email address there, and I will try to answer your question as soon as possible. Thank you very much.